Hello guys, so today we're going to cover pediatrics. Specifically, we do ETAT and IMNCI. So today I'm with my bot lady here called Mrs. Helen. She'll take us off, then I'll pick on the way. So she'll be my co-teacher. Listen and enjoy. So let her define what poisoning is. We are starting with poisoning in children. So let's listen.
A poison is any substance that harms the body and interferes with the body's normal functioning. Poisoning can occur through poison ingestion like paraffin, paracetamol alcohol, OP, insecticides, inhalation of carbon monoxide organophosphate, OP, poison, skin exposure, eye contact, or any other mode that causes adverse effects.
Well, we've had the definition of poison. We can also define poison as any substance that is harmful to our bodies. So the substance can be swallowed, inhaled, injected, or absorbed through the skin. So any substance can be poisonous if you take too much of it. So, and the poisons can also include over-the-counter drugs, which are taken in high doses. So let Mrs. Helen take us through the general clinical features of poisoning.
General clinical features of poisoning: vomiting and hematmesis, convulsions or involuntary movement, oculogyric spasms, hallucinations and agitation, pupils either dilated or constricted, renal failure, respiratory failure, cardiac failure, hypoglycemia, metabolic acidosis, stupor/coma. General management: the blood should be tested for the poisonous taken. An intravenous infusion using Darrow's solution of 50% dextrose may be given to correct hypoglycemia. Oxygen therapy can be administered where necessary. The child should be given oral alkaline fluids to neutralize the acid and vice versa. Urinary catheterization is indicated in order to monitor urinary output when renal failure is suspected. The patient's general condition should be assessed to include level of consciousness and inspection of the mouth and lips for any burns in case of corrosive poisoning. Neurological investigations should also be undertaken.
Alright, next is kerosene/paraffin poisoning, and we know that children can access this commodity in the house and take it by accident, drink it by accident. However, they are not likely to drink more than a mouthful of it because of its unpleasant taste. Now, the main danger is that if they take kerosene, they will have aspiration into the lungs, they will have bronchopneumonia. So we don't induce vomiting. I've seen questions testing that when a child drinks kerosene, you don't induce vomiting. So it can also, the kerosene can also cause acute pulmonary edema, and also they can also slip into coma because of the narcotic effect of kerosene, as you can see on the screen. So management, we are saying do not induce vomiting. That the bottom line is do not induce, and do not wash out the stomach. You can give 5 ml of milk of magnesia as a laxative, and you can also start pneumonia treatment immediately, because we said the main risk lies in the fact that kerosene could cause bronchopneumonia. Now, insecticide poisoning, you call paraffin, malathion. When a child comes into contact with these poisons, they are likely to have tremors of the muscles, they can sweat, copious secretions of saliva, lacrimation, they can have pinpoint pupils. And in the later stages, they can have convulsions, can slip into coma or a paralysis. Those are some of the manifestations of a child who was taken or who was had insecticide poisoning. So treatment consists of first washing the child with soap and water. If they had skin exposure, you can give them large doses of atropine, IM. In children under 5, we give 0.5 milligrams. In older children, you give 1 milligram. I used to see this question somewhere as we were revising our FQE papers. So for children under 5, you give 0.5 mg. In older children, you give 1 mg. Atropine sulfate, IM, every 15 to 30 minutes until the pupils become white. Didn't we talk about lacrimation? Contact with the poisons may cause lacrimation. So conflicts with disorders like childhood seizures. The causes of seizures have been identified as excessive neuronal discharges. Can have hyperexcitable nerve cells, neurons overfiring without regard to stimuli or need. Sometimes a child is born and they have seizures and there's nothing you can do about that. But we can diagnose seizures by use of an EEG. You know what that means in full? Each seizure will have a characteristic EEG tracing. So nursing diagnosis for seizures, we have infective airway clearance, risk for injury, disturbed sensory perception. So interventions of seizures, you monitor vital signs, you monitor neurologic status, you stay with the child during a seizure activity, move the child to a flat surface, place the child on their side to allow saliva to drain out. Do not try to interrupt the seizure to promote safety. You support the head and keep the child's hands from inflicting self-harm. That is a quick snap through of the interventions of seizures. Now, let's look at ETAT, that's Emergency Triage Assessments and Treatment. ETAT, that's what it stands for. It is for emergency triage assessment and treatment plus admission care of newborns and children in the first 48 hours. Triage is necessary in the hospital. As we all know, we rapidly screen sick children soon after their arrival in hospital. Categories of triage: we have children with emergency signs. Those ones require immediate emergency treatment. Those with priority signs can be given priority in the queue. Children with non-urgent cases or signs, they may either have emergency nor priority signs and therefore can wait or do not need emergency to be attended quickly. Emergency signs include obstructed or absent breathing, severe respiratory distress, central cyanosis, any signs of shock. If they have cold hands, cold extremities, those are emergency signs. Coma, convulsions, signs of severe dehydration. And children with these signs require immediate emergency treatment to avert death. Priority signs include the 3T, P2R. Tiny infant temperature, the child is very hot, trauma, pallor, poisoning, pain, respiratory distress, and the child will be restless. Referral, we used to abbreviate these as 3T, 3TP, R, MOP. Very simple like that. 3TP, 3TP, R, MOP. That is tiny infant temperature, child is febrile, trauma, or any other surgical condition, pallor, poisoning, pain, respiratory distress. The child might look restless, and there is urgent need for referral, malnourished, edema of both feet, and burns. The mnemonic is there, 3TPR MOP. These children need prompt assessment. They should not wait in the queue to determine what further treatment is needed. So all these children should be moved with any child with a priority sign, with priority signs should be moved to the front of the queue to be assessed. So principles of ETAT include the ETAT program is about more than identifying and treating sick newborns and children. ETAT requires total collaboration of health workers and caregivers. ETAT gives a structure for rapid and comprehensive approach to initial assessment and intervention based on the acronym ABCD. The four approaches of ETAT. So the ABC approach to triage, the ABC approach to basic life support, the ABCD approach to provisional emergency care, the ABC approach for newborn resuscitation. Those are approaches of ETAT, and we have also looked at the principles of ETAT. So those two are different.
Thanks Joash for that. You have really hurried through that part, but it is okay. I heard you ask about EEG, and I wish to state that EEG is for electroencephalogram, a recording of the brain activity. Now, I wish to take you through IMNCI. Definition of IMNCI. It is integrated case management process used by doctors, nurses and other health professionals who see sick newborns and children up to 5 years of age. It is a case management process for a first-level facility such as a clinic, a health center or an outpatient department of a hospital. Integrated case management relies on case detection using simple clinical signs and empirical treatment. Major causes of childhood morbidity and mortality, WHO, 2015 up to date. Top 10 conditions. Birth asphyxia and birth trauma, it accounts for 15%. RE, 14%. Prematurity 13%. Congenital anomalies 9%. Perinatal and nutritional conditions. Diarrhea 7%. Sepsis 7%. Injuries 7%. HIV/AIDS 6%. Malaria 5%. Significance/purpose/aims of IMNCI in reducing under 5 morbidity and mortality. To describe how to care for a child who is brought to a clinic with an illness, or for a scheduled follow-up visit to check the child's progress. How to routinely assess a child for general danger signs, or possible bacterial infection in a young infant, common illnesses, malnutrition and anemia, and to look for other problems. In addition to treatment, the guidelines incorporate basic activities for illness prevention. IMNC layout. 3 rows with distinct colors for quickly identifying if the child has a serious illness. The child needs urgent attention. The child needs treatment/intervention with drugs. Application of the IMNCI booklet guidelines. Color coding. Pink equals severe classification needing admission or referral. Yellow equal A classification needing treatment/intervention. Green equal not serious, and in most cases no drugs are needed. 6 elements or steps of IMNCI. 1. Assess a child by checking first for danger signs, or possible bacterial infection in a young infant, asking questions about common conditions, examining the child, and checking nutrition and immunization status. Assessment includes checking the child for other health problems. 2. Classify. Classify a child's illnesses using a color-coded triage system. Because many children have more than one condition, each illness is classified according to whether it requires urgent pre-referral treatment and referral, red, or specific medical treatment and advice, yellow, or simple advice on home management, green. 3. Identify treatment. Identify specific treatments for the child. If a child requires urgent referral, give essential treatment before the patient is transferred. If ACLD needs treatment at home, develop an integrated treatment plan for the child and give the first dose of drugs in the clinic. If a child should be immunized, give immunizations. 5. Counsel the mother. Assess feeding, including assessment of breastfeeding practices, and counsel to solve any feeding problems found. Then counsel the mother about her own health. 6. Follow-up care. When a child is brought back to the clinic as requested, give follow-up care and, if necessary, reassess the child for new problems. General danger signs in IMCI. 1. Ask, is the child able to drink or breastfeed? A child has the sign not able to drink or breastfeed if the child is not able to suck or swallow when offered a drink or breast milk. 2. Ask, does the child vomit everything? A child who is not able to hold anything down at all has the sign vomits everything. 3. Has the child had convulsions? During a convulsion, the child's arms and legs stiffen because the muscles are contracting. The child may lose consciousness or not be able to respond to spoken directions. Ask the mother if the child has had convulsions during this current illness. 4. Look to see if the child is lethargic or unconscious. A lethargic child is not awake and alert when she should be. The child is drowsy and does not show interest in what is happening around him. Main symptoms in IMNCI. 1. Cough or difficult breathing. 2. Diarrhea. 3. Dehydration. 4. Fever. 5. Ear problem. 6. Malnutrition and anemia. 7. HIV exposure. 8. Assessment of child developmental milestones. Other problems. 1. Ask, does the child have cough or difficult breathing? Difficult breathing is any unusual pattern of breathing. Mothers describe this in different ways. They may say that their child's breathing is fast or noisy or interrupted. Ask, for how long? A child who has had cough or difficult breathing for more than 30 days has a chronic cough. This may be a sign of tuberculosis, asthma, whooping cough or another problem. Count the breaths in 1 minute. If the child is 2 months up to 12 months, the child has fast breathing, 50 breaths per minute or more. 12 months up to 5 years, 40 breaths per minute or more. Look for chest indrawing. If you did not lift the child's shirt when you counted the child's breaths, ask the mother to lift it now. Look for chest indrawing when the child breathes in. Look at the lower chest wall, lower ribs. When chest indrawing is present, the lower chest wall goes in when the child breathes in. Look and listen for stridor. Stridor is a harsh noise made when the child breathes in. A child who has stridor when calm has a dangerous condition. Assessment of pneumonia according to IMNCI. Signs classify treatment. 2. Diarrhea. What are the types of diarrhea? 1. Acute diarrhea. If an episode of diarrhea lasts less than 14 days. 2. Persistent diarrhea. If the diarrhea lasts 14 days or more. 3. Dysentery. Diarrhea with blood in the stool, with or without mucus. The most common cause of dysentery is Shigella bacteria. Amoebic dysentery is not common in young children. How to assess a child with diarrhea? Ask about diarrhea in all children. Ask, does the child have diarrhea? If the mother answers no, ask about the next main symptom. If the mother answers yes, or if the mother said earlier that diarrhea was the reason for coming to the clinic, record her answer. Then assess the child for signs of dehydration, persistent diarrhea and dysentery. Ask, for how long? Diarrhea which lasts 14 days or more is persistent diarrhea. Give the mother time to answer the question. She may need time to recall the exact number of days. Ask, is there blood in the stool? If she has seen blood in the stools at any time during this episode of diarrhea. 3. Dehydration. When a child becomes dehydrated. Signs includes restless and irritable. If dehydration continues, the child becomes lethargic or unconscious. As the child's body loses fluids, the eyes may look sunken. When pinched, use your thumb and first finger. Do not use your fingertips because this will cause pain. The skin might go back slowly or very slowly, longer than 2 seconds. Note, in a child with marasmus, severe malnutrition, the skin may go back slowly even if the child is not dehydrated. In an overweight child, or a child with edema, the skin may go back immediately even if the child is dehydrated. Even though skin pinch is less reliable in these children, still use it to classify the child's dehydration. When classifying diarrhea, all children with diarrhea are classified for dehydration. 3. Classify dehydration. 4. Fever. A child with fever may have malaria, measles or another severe disease. Or, a child with fever may have a simple cough or cold or other viral infection. Fever is the main symptom of malaria. Fever and a generalized rash are the main signs of measles. How to assess a child with fever? Ask, does the child have fever? Check to see if the child has a history of fever, feels hot or has a temperature of 37.5 degrees Celsius or above. Feel the child's stomach or axilla, underarm, and determine if the child feels hot. If the child has fever, by history, feel, or measured temperature of 37.5 degrees Celsius or above, assess the child for additional signs related to fever. History of fever is enough to assess the child for fever. Assess the child's fever even if the child does not have a temperature of 37.5 degrees Celsius or above or does not feel hot now. Decide the malaria risk. To classify and treat children with fever, you must know the malaria risk in your area. There is a high malaria risk in areas where more than 5% of the fever cases in children are due to malaria. There is a low malaria risk in areas where 5% or less of the fever cases in children are due to malaria. There is no malaria risk in areas where no transmission of malaria occurs. Look for mouth ulcers. Are they deep and extensive? Look inside the child's mouth for mouth ulcers. Ulcers are painful open sores on the inside of the mouth and lips or the tongue. They may be red or have white coating on them. In severe cases, they are deep and extensive. When present, mouth ulcers make it difficult for the child with measles to drink or eat. Look for pus draining from the eye. Pus draining from the eye is a sign of conjunctivitis. 5-year problem. For all sick children, ask the mother about the child's problem. Check for general danger signs. Ask about cough or difficult breathing, diarrhea, fever, and then ask, does the child have an ear problem? If yes, is there ear pain? Is there ear discharge? If yes, for how long? Look and feel. Look for pus draining from the ear. Feel for tender swelling behind the ear. 6. Malnutrition and anemia. Check and classify malnutrition/anemia. After taking height/length and weight, use the tables in IMCI chart booklet to determine the Z-score. Measure MUAC in a child 6 months or older. Check for edema of both feet and any other medical complications. 7. HIV exposure and infection. Check for HIV exposure and infection. Children may acquire HIV infection from an infected mother through vertical transmission in utero, during delivery or while breastfeeding. 8. Assessment of child developmental milestones. What is care for child development? Care for child development include play and stimulation interventions in early life to promote the following skills: physical, social, emotional, language and cognitive development skills. This is done through responsive interactions between caregiver and the child by talking, playing and providing a stimulating environment. Child skill domains. 1. Physical/motor skills. This involves coordinated movements, reaching and grabbing, follows objects with eyes, turns head towards sound sitting, crawling, standing. 2. Cognitive skills. This involves changes in child's thought, intelligence, and language. Seeing, hearing, moving, touching. Recognize people, things, and sounds. Compare sizes and shapes. 3. Social skills. This involves changes in the child's relationships with other people. How he/she communicates interests and needs. Expresses self through verbal and nonverbal skills. 4. Emotional skills. It involves having appropriate emotional reactions to own efforts and other people. Being able to receive and express appropriate emotions and affection. And with that, together we say, thank you.